So yeah, we should recognize that CGM is a powerful technology, and but here we are talking about a specific population where it's a drug naive patient and before starting any therapy. So in insulin treated patients, yeah, CGM has demonstrated to have clear benefits in reducing A1C, hypoglycemia, and improving the quality of life. But for this cohort, the current evidence does not support CGM as a standard fine first line tool. And in drug naive patients, here individuals newly diagnosed with type 2 diabetes, we have established standard markers like A1C, fasting plasma glucose, and oral glucose tolerance test. And what you do initially, the fundamental approach is to inculcate lifestyle modification based on diet, exercise, and weight management. So, overdiagnosis and of variability, CGM may flag minor excursions that are clinically irrelevant, no proven outcome benefit, no large RCTs to demonstrate reduced micro or macrovascular events from using CGM before therapy, and it also has an amount of patient burden and resource utilization where unnecessary CGM use diverts cost and clinical time from high risk patients. Coming to cost, CGM is cost effective only in insulin treated patients, not in early type 2 diabetes with mild hyperglycemia. So, what are the guidelines say? None of them recommend universal CGM use. The ADA 2023 CGM may be considered in select type 2 patients with insulin or with unexplained hyperglycemia. So, the ACE 2022 says recommends CGM primarily in insulin users, high risk patients, or when A1C and SMBG data are unreliable. So ESD 2023 consensus statement says no recommendation for routine CGM or diagnosis. Focus is still on A1C and SMBG. So there's no society that endorses CGM as a blanket requirement, in drug naive patients. So the ADA standard of care 24-25 also says offer CGM to people with multiple daily injections or consider CGM for basal insulin users, but for non-insulin therapy, intermittent professional CGM may be used for specific pattern assessment, not mandated before starting drugs. The ACE and ACE 22-23 guidelines says endorses CGM for insulin users and for non-insulin type 2 diabetics, use case by case to guide management. Even the NICE guideline says that it is recommended for type 1 patients, whereas type 2 patients it's limited for specific clinical scenarios. The AD and EST 2022 consensus also says hyperglycemia management emphasizes on lifestyle and evidence-based pharmacotherapy as first line. So CGM is just a supportive technology in selected contexts, not a prerequisite to start therapy. So when it comes to early type 2 diabetes, there are few studies which says like Martin et al. Where CGM plus lifestyle reduces A1C by 1%, but benefit was comparable to structured SMBG. So Herat et al. In 2019, there was more than 70% who avoided pharmacotherapy who used CGM feedback, but this was in selected motivated population because people who have where CGM are all motivated, they exercise, diet, and there are different sect of people. So no head-to-head trial shows CGM superior to structured SMBG for early glycemic control when no drugs are started. So excessive data may not only confuse the patient, it may burden the physicians as well. So smaller transient glucose spikes may prompt unnecessary anxiety and over-treatment. The patient may want to increase treatment by himself or pressurize the doctor to do so. So there are like in non-insulin drug naive type 2 diabetic patients, there are RCTs in non-insulin which are very small, short duration and often open label, showing modest A1C reductions of only 0.3 to 0.5% when compared to SMBG. And durability is uncertain. There are many positive trials like what my opponent just spoke, but these include trials that include intensive education, frequent follow-ups, digital nudges, confounding the independent effects of sensors. So no RCT evidence shows CGM before initiating therapy improves long-term complications, hospitalizations, or mortality in drug-naive type 2 patients. So this is a step RCT show that significant A1C reduction and more timely intensive physician actions with structured SMBG in insulin naive type 2 patients. So benefits persisted and improved process of care metrics. This approach is low cost, scalable, and ideal before initiating titrating therapy. So practical template would be a 7-point SMBG at least 3 consecutive days before visits with actionable pattern review. So structured SMBG saw a zero point 0.5 to 0.7% reduction in A1C, improved physician decisions without CGM. So CGM RCTs in non-insulin type 2 patients also had similar A1C reductions when compared to SMBG when combined with coaching. So head-to-head findings, there is no statistically significant superiority of CGM over SMBG in non-insulin newly diagnosed patients. So for early type 2 diabetes, structured SMBG achieves similar outcomes at lower cost and with less complexity. So these are some of the studies, like the first impact, diamond, wisdom in type 1 patients, mobile and city trials was done in type 2 patients. So they demonstrate CGM benefits mainly in insulin treated patients with a reduction of A1C of zero point 0.4 to zero point 0.6 with lower hypoglycemia. So no major outcome trials prove that CGM before starting therapy in drug naive patients changes hard endpoints like CV events or microvascular risk. So extrapolation of insulin cohorts to untreated patients is unsupported by data. So evidence-based is context-specific and not universal. So coming to India specific, see here CGM is mostly out of pocket, it's expensive, and it only lasts for 14 days. So RSSJ 2023 advises judicious use in selected patients, not universal deployment at diagnosis. The ICMR Diabetes India consensus also says structured SMBG, quarterly A1C are adequate for early management, and public health focus prioritize affordable drug access, education, and follow-up over device-first strategy. So there is something called lag time and inaccuracy, because the CGM measures the interstitial glucose and not blood glucose. This results in is inherent physiological lag time of 5 to 15 minutes, which is a known limitation. While MARD values are improving, CGM devices are not 100% accurate and may be affected by factors like compression, loss, or certain medications. Also, what is seen is as the blood sugars are near to normal, the MARD increases. So we cannot rely upon those readings to actually advise your patients. So there's also in drug naive patients, a less precise tool may provide a false sense of security or cause unnecessary anxiety. So when to consider CGM early, suspected unrecognized hypoglycemia, discordant A1C versus SMBG, shift work, pregnancy planning, or inability to perform in SMBG. There are exceptions aligning with selective guidance. Prefer a short-term professional CGM with formal analysis or routine personal real-time CGM before therapy. So you have to reassess your patient once in 3 months of lifestyle and pharmacotherapy. Only then escalate monitoring, only if it will change the management. So when not to use a CGM pre-therapy, newly diagnosed patient, because A1C is going to be less like 6.5 to 7.5%, the patient is not going to have any symptoms, and you have reliable other methods like A1C, SMBG data, patients with good literacy and adherence, cost-sensitive environments like our country. So when to selectively consider a CGM, atypical presentations where there's discordant between A1C and SMBG readings, high glycemic variability or hypoglycemic suspicion despite no therapy, or patients unable to self-monitor capillary glucose, pregnancy planning or shift work with unusual glucose patterns. So prefer short-term professional CGM instead of long-term personal CGM. So practical implementation in early type 2 diabetes, confirm diagnosis with an A1C or a fasting plasma glucose, initiate lifestyle intervention, first line therapy. So it should be either metformin or organ protective agents. Use structured SMBG for feedback, review in 3 months. Escalate monitoring to CGM only if data gaps remain or therapy intensification is needed. So CGM is valuable tool but not required before starting therapy in every drug naive type 2 patients. And structured SMBG A1C monitoring effectively guide early therapy decision. Guidelines, whatever the ADA, EST, ACE, NICE, RSJ do not recommend early use of CGM are not for universal blanket use. So the rational deployment preserves resources for high-risk patients where CGM impact is proven. So start simple, diagnose, lifestyle, first-line therapy, structured SMBG, escalate only if needed, avoid technology overuse that doesn't change management, reserve CGM for complex or high-risk cases, not routine prescriptions. This approach is evidence-aligned, ethical, patient-friendly, and cost-conscious. So some of the RCTs what you showed were very small in number, underpowered. So I don't think we should go by those studies. And it's all AI generated.
So, so thank you, Karthik, for letting us know that we should not use the CGM.